Hello, and welcome to episode number 10 of the Past Your Prime podcast. My name is Alex. I am a professional volleyball player with enormous calves. This is Craig. He's a doctor of physical therapy. Say something, Craig.
Hi, I'm Craig. Ooh, I think I nailed that one. That was actually the first time.
Yeah.
I'm a physical therapist
Patient problem pathology.
with patient problem pathologies, issues with alliteration, and obviously identifying myself. Those are my biggest issues.
All right. Let's go into injury updates with Alex and Craig. How's your neck?
Man, neck is dramatically better.
Nice.
This time, I learned my lesson that I will not quit doing the home plan. I double negative on that one.
Yeah.
I will continue to do my home plan, which is all around thoracic mobility. When I'm doing it, it completely resolves my symptoms. But for some reason, like most people, I get too busy, and when I'm feeling good, I don't get the feedback loop of disgusting neck pain to tell me to do my home plan. So I'm trying to do it without the pain needing to be the reminder.
Nice.
How about you?
My wrist is a little bit better comparatively to last week when it got blown up. My TFL is flaring up a little bit, probably just because I hit more plyos this week and did an extra day at the gym. But I ran for 10 minutes straight. 10 minutes straight run at a 4.5 speed on the treadmill.
That's incredible.
Yeah.
So you're basically like...
and I think I could have gone a mile. I think I found my speed for the treadmill where I can run, not indefinitely, but like I probably could have got to 12 minutes.
Oh, that's actually pretty exciting. So you are officially a 10-minute runner.
Not a 10-minute mile, but
No, an actual...
can run for 10.
He can run for 10 minutes.
Consistently, yeah.
Yeah, so if the end of the world happens, and you have to be able to run 10 minutes, you've got it.
Yeah.
You've got it in the bag. Do you still...
As long as the zombies are very slow.
So if is it Day of the Dead, the one where they can actually sprint, you've got to be careful of that type of zombie apocalypse, but more of like the shambling, pathetic, slow zombies.
Yeah, Walking Dead zombies, I think I've got that.
Oh, yeah. Yeah, how those zombies took over the world, I don't get it. Those should not have been that bad. So,
and how'd they get Glenn? It just made me sad. Have you seen that show?
Well, Glenn gets brained. He gets his beaten to death by actual other humans. If you just started watching that, I'm sorry, but you should have caught up earlier. Anyway, on that note.
Alrighty. Today we are going to switch it up a little bit and kind of do a case study on knee pain, knee issues.
Yeah.
All right.
Yeah, case study.
I'll look at that.
I wouldn't say a case study. We're not going to go into we could go into a specific case, but more I think that I have a strong disagreement where people think that knee pain is easy and simple. I couldn't disagree more. I think it is a joint in the area that has a lot of pain, has a lot of issues. I think that there's a significant amount of complexity to it. And I think that complexity matters. The nuance and how you treat it matters. And I don't know if that viewpoint's shared by everybody.
Yes. You're like a knee expert. In your clinic specifically, lower extremities are your kind of wheelhouse.
I like to treat.
Yeah. You've gotten, by your own token, a lot better at lower extremity issues over the past 10 years. You also are a scholarly researcher, so I hear you took it upon yourself to go to the scholarly article repository of YouTube.
I did. Oh, wow. Yeah, I did.
What did you find on the YouTubes regarding knee pain?
Well, let me give you my search strategy was I typed in knee pain, and everything was somehow linked towards an exercise to solve knee pain, an injection to solve knee pain, or something around fix knee pain fast. And almost all of them seemed... idiotic's not the right word. They were overly simplistic and optimistic around what happens to most people when they develop knee pain. I was very unimpressed. Yeah.
So you're telling me that there's not one single exercise that can fix knee pain?
I don't think there is a single exercise that can fix knee pain.
Blasphemy.
Yes. It definitely what I realized is for us to go huge and become viral, I think we do have to say that it's simple. Here's the 3 simple, easy, fast fixes for solving knee pain. I realize that the copy that you use to describe your videos matters a lot, and having a stupid face pointing towards some words like fix knee pain fast is actually how you get people to watch your video. I think we still use those words when we put this up, and we'll cut it up so that people will actually look at it. But I think that's dumb. I don't think it's actually accurate.
All right. So given that, what are the biggest myths around fixing knee pain?
Wow.
From your YouTube research?
Wow. So biggest myths, man, there was a few that were pretty wild. Let me see. The first one that I think I over and over again have said, partially in this podcast, but if anybody where they've been at a lecture of mine or seen me in person, I'm not a huge stretching fan. And the amount of times where somebody comes in with a joint effusion and an irritated knee, so you can have a joint that gets irritated, any joint that can move in your body, you can traumatize. We call it a traumatic synovitis or a traumatic arthropathy. Basically, you jam a joint. If you stretch a jammed joint, you make it worse. A large portion of the videos talked about stretching as one of the fixes, especially your quad. That's a huge one. You have to make the assumption that you're not going to make stuff worse. I often see that it does make it worse, especially if there's a meniscus involved and joint involved. So I'd say that's the top one. The next one is that everything involves the hip. I do think the hip is really important. Sometimes you'll hear us talk about the knee joint being a stupid joint, meaning that it really only flexes and extends, which is also not true. There's components of internal and external rotation that happen to the knee joint, and adduction and abduction, all those things happen there. It's just like the giant majority of motion is in flexion and extension. And so your hip moves in all 3 motions quite a bit, and it has a huge impact on your function of your knee, but it makes you overlook the really important things that are actually happening at the knee. It's not just get your butt stronger or prevent knee valgus, which is where your knee dives in, which we'll dive into deeper. The hip doesn't solve every issue at the knee. When somebody comes in, those for me, aren't the biggest predictors of if the person's going to get better.
Like there's some relation, but it's not a direct correlation.
It's it's a piece of it, and the overemphasis on it leaves extremely obvious injuries, which we see these in the clinic too, where people have had treatment, significant treatment, and they've been doing clamshells and glute exercises forever, and their glute still tests weak, and they still have knee pain. It's one of my points is that there can be times where you're not actually dealing with like a glute weakness or a hip weakness, musculature weakness. You're actually dealing with inhibition that's being driven by joint irritation at the knee. There's these pieces that you can suss out and really delve into within the exam, both the structural and functional exam, to determine the pain generator and how the pain generator is influencing your biomechanics.
Alrighty.
So that's 2. There's one other one. Let me see. Oh yeah. The last one was, I think it looks cool as a photo, but it's showing the location of your pain, right? And we'll go through and we're going to do a palpation exam today. The location of the pain, while it's important, it's not the same as like your hand or your foot, where you feel the pain is typically right where the pain generator is. So oftentimes with structural injuries, you can have what's called a local symptom or a referral symptom. Local means where you feel it is the structure that's causing the pain, right?
Like right on that spot.
Right on that spot.
Yeah.
The most obvious example would be if you burn your hand, you could close your eyes and point right to that burn. The knee doesn't have the same receptor field density as like the foot or the hand. And so you can still have referrals that are really common to the knee. Going by the picture that I saw all over on those videos where people walk through it, I wish it was that simple. It just isn't.
Yeah. I feel like I've had the same when talking about my shoulder, where it's like, where does it hurt? Everywhere. I don't know. Yeah, I don't know where it hurts.
And it is funny. Yeah. I get why you want to make it simple, and I get that piece of it. It's just I don't think it is simple, and there's so many other components of it, and that's why understanding what problem is you're trying to get. Is it a diagnosis problem, or is it, hey, I know what it is, but I don't know how to manage it without abusing myself with Tiger Balm.
And it's a super complex joint. You've got whatever ligaments, cartilage, lots of moving pieces in there. I don't know anything about them really, just that mine have generally been healthy, knock on wood.
Oh, dude, you just sabotaged yourself.
I know. That's
Why did you do that? Especially as a volleyball player. Yeah, you're ruined. He's planning on playing again.
I hope so.
Yeah, he's totally going to be. I feel really bad for you now.
Okay. Why do so many people kind of get this wrong when looking at knee pain?
Why do people get it wrong? I think the biggest component is that when we look at the diagnosis and the way that you do the exam of any joint in the body or any area in the body, I believe it's one of the most simple, but it's also one of the most sub. What that means is that there's components of the tests that actually matter, like the way that you do it. And every time that we look at the test, and this is something that we take, my staff and a lot of other individuals take from the literature and ways that we've been trained, but it's what's the quantity of motion that you have, what's the quality of the test, and what's the provocation. You have these things that you really have to dive into. So for example, when you're bending somebody's knee, you're going to have times where if it indicates like a joint irritation, you'll lose knee flexion and it'll be painful. And it could be painful in the front or the back, or you could have muscle guarding. So there's like a difference in like figuring out the difference between muscle guarding versus the joint itself having like what we call a capsular infield. So these pieces that you can't really self-assess. I'll show you how you try to, but if you're missing motion, you're not going to have a simple fix. There could be something that we figure out, but you have to rule out meniscus, which aspect of the meniscus, and if it's joint, or if there's something else that's, common referral area is from the hip to the knee, the front of the knee. So you can have these other pieces that are just make it more difficult. And so these assumptions on a single exercise is going to fix it is what I think people get wrong.
Yeah, I think once we do the exam, you'll see that, like, I reference NFL games all the time. You see massive knee injuries in NFL games, and you see the team doctor or PT or whatever come out and start doing weird things with the guy's knee. And like, I know from experience, and several times that I've come into Craig's clinic, like, I've torn my ACL, I've torn my meniscus, and he's like, no, you're fine. It's all connected. Like, you're going to be okay.
100%. There's a big issue, especially depending on when you test it, with false negatives. So all I'm saying is that there's a lot of stuff that goes into the exam, and when we go into go head in there, we're gonna show you what it looks like and walk through what things I'm rolling in and what things I'm rolling out.
All right, should we head in there and look at those now?
Yeah, we're gonna head in there and let's jump into it. Okay, so here we go. Now, best laid plans. Alex and I actually recorded this. We obviously had our typical chatter back and forth, but unfortunately the audio did not record well for this clip, which is me explaining the basic knee exam. What you're seeing right here is me flexing Alex's knee, and I'm clearly using too many words. But what I'm doing is I'm bringing the heel to the butt. So he's laying flat on his back, bringing his heel to his butt. When you go into flexion, your knee actually goes into a little bit of internal rotation. So you can see I'm kind of moving it internal, external rotation, just to see if it feels good. Typically, you feel more comfortable if you go into a little bit of internal rotation. That's where your toe goes in a little bit more. Now I'm going into extension. So you can see I moved his leg into extension, and then I'm trying to give a little bit of overpressure. When we talk about different diagnoses, if you're missing a little bit more flexion on one side versus the other, we're starting to think there's a little bit of a joint component, or there could be a posterior meniscal injury. Really what that means is that there's an interarticular issue that's driving some of your symptoms. And so that's the part where I was talking about before, where you're starting to really figure out what structure is causing the pain that the person is experiencing. If you can't bring your heel to your butt, that can often indicate that you have a little bit of an interarticular issue. Now you see me putting them in about 80 degrees of knee flexion, checking internal and external rotation of the knee where I'm bringing the foot in and out. Good. And now I'm checking his different ligaments, and that's him scaring the crap out of me. I thought that I actually just ripped his leg apart. Anyway, I'm checking his LCL, and there's a little bit of a give in it, and you can actually get a firm infield. Cool thing with checking the ligament tests is that you actually get a good feel for if the ligament's actually damaged. So now I'm checking the inside of his knee. That's going to be your medial collateral ligament. You can see I'm just putting a little pressure. And if somebody has pain with that, that indicates that there's an MCL strain. Okay, now I'm about to do a Lockman's test. Lockman's test is just checking your ACL, the infamous ACL, which is one when people tear, ruins their whole career. You're just looking to see that there's stability. Now, if you notice laxity side to side, it means that you might have either strained or torn or completely ruptured one of those ligaments. Trust me, if I'm doing this, you would have already had a mechanism that typically tells you have it. And now I'm doing a little bit of a test to catch a posterior horn meniscus lesion. So if you're getting pain or symptoms locking when your knee is moving and you feel more in the back of your knee, those are types of things that start to make you think, okay, let's just make sure that there's not a meniscal component to it. Now I'm applying a little resistance where he's trying to kick his knee straight. Now he's trying to bring his heel to his butt. That's going to rule out either the quadriceps and the extensor mechanism, or I'm ruling out the hamstring and that whole biceps femoris, semitendinosus, semimembranosus. Those are all muscles that flex the knee, which collectively are called your hamstrings. All right, so now one of the more common functional tests that we'll use is a step-down test. Now, the step-down test is really useful because it can show dysfunction at the hips, and it can also show if we call it the extensor mechanism, if his ability to load through the quad, through the patellar tendon into the knee is a piece of his pain. And so what we want to see is when he goes down, this stays even, his knees don't hit each other, and that he's able to slowly tap the ground. So I'm going to have him go ahead and go. So what you'll notice with it is that his knee is actually staying really stable. You can see that there's no diving in of the knee. The knee doesn't dive in at all. You're not seeing it collapse into a vertical or into a horizontal motion as it goes down. Do one where it dives in. So that would be a horrible mistake, the one he just did. That's where it looks like his knees are hitting each other. That's a common one that people will put on the YouTube to show, hey, if we correct this motion, now you don't have pain. Okay, well, you fix the functional issue, but what structurally is actually causing the symptom? Are your quads getting tired yet?
Yeah.
Just keep going. We'll see when he fails. Perfect. Let's head back in.
And we're back in the studio.
Like magic.
Yeah, that was fun. A little bit of time skipping.
Yeah, how are your quads right now? I know we just made you do an endless number of step downs. It was actually quite a bit more than what you guys just saw.
I do those on a regular basis, and that is the leg that's slightly better than the other leg, so it wasn't that bad, actually. I normally do them weighted for extra resistance. At one point, I was up to about 50-pound kettlebells in each hand.
Wow,
doing those.
Okay.
So, but I feel like that was making my TFL angry, so I've lowered
Quit doing that?
Yeah.
Your TFL, man.
That's all right.
That TFL is just coming at you sideways.
Anyway.
Well, yeah, hopefully you don't get a serious knee injury. You've been tempting the gods. All right, so yeah, let's go ahead. Where are we at?
I think we were going to talk about the difference between structural and functional knee pain, which I think you did some assessments for those there.
So yeah, we kind of hit it. We just hit it with the step down test. You have to look at the basic exam, the findings from it, and then you have to relate it back to what you see in the functional exam. If you don't do that, you actually don't know what's causing the changes in whatever functional thing you're catching. The most common one, most obvious one is knee valgus, where those knees seem to be coming into each other. That's a combination of hip, adduction, internal rotation, and that causes this motion at the knee that looks like horizontal motion, almost looks like the knees diving in. That piece of it it's good to know when that happens because it tells you what type of treatment things you probably also want to do, but you always have to relate that back to what you found in the exam.
Yeah. So we've just seen the exam. What actually works for knee pain? I know we talked about myths earlier, but let's kind of jump into how to fix these things.
Okay. We are going to step back into the gym for a second, but I want to work through kind of the concept.
Okay.
Is that fair?
Yeah.
First off, it's always, you have to verify that you have the right diagnosis
What is the problem?
What is actually the problem? It is extremely common to have multiple pain generators with a knee issue. For example, somebody that comes in, they did a hard landing off of a, what do you call that? Where you hit it really hard playing volleyball?
A spike, maybe a slam.
I do feel when I say that sometimes it seems as if an important part of your soul dies when I don't know the term for volleyball.
I actually quite enjoy it.
You do?
Because you just sound like an idiot.
I sound like a moron. Yeah. I probably, there's a lot of volleyball players out there that it has to go. Like, I would never
trust this guy.
I've never trusted this person. I always find that funny because I'm not interested in the sport as much as I am interested in how you hurt yourself and then how you actually exercise and do the activity. I always find it funny when somebody wants to be a coach, like a sports coach, right, and teach the thing. I don't care about that at all. I care about the injury mechanics, the pathomechanics, how you train through and make sure that the movement and stuff feels really good.
Yeah, the problem pathology.
The problem pathologies.
Oh, just get him going.
I love how people hurt themselves. It is, it's what got me to triathlon and running and volleyball. But anyway, I digress. The problem, you have to understand what the diagnosis is and then relate that back. That's the first thing. That's a number one thing. If you have a random improvement in an exercise, that's not diagnostic. So all those quick fixes, all those things, it's a piece of it. And the way I always kind of look at it is, what did you find in your basic exam? What are you seeing in your functional exam? What type of treatment response do you get? Our team uses what's called the treatment hierarchy, but what do you see actually makes that person's main problem actually feel better? If it's the step down test, we can use something called a surf strap that would correct that knee valgus issue that we just showed where his knee dives in. We could also do something where you do a medial heel wedge that posts his heel up, so functionally he can't over pronate and do what's called talocrural coupling, but it's where you go into pronation, that pulls your tibia into internal rotation, which then pulls your femur into more internal rotation. All of that stuff can happen, and you can do these little artificial stability tools that force it to not happen. Those are all, so now we have three separate things that now go, okay, we had an exam that makes sense for this problem. We have a functional exam that then would overload that what we found in the structural exam. And now we did a treatment response based off those two things and saw that it got better. Now you have three separate things that then give you a lot of information that you have the right problem. And then the final piece is you dig through what thing is hurting the person, what triggers, what things all line up together. And you have a really cohesive picture that gives you a ton of information on how to actually attack the problem, which at the end of the day is, do you have the right tissue? Are you able to make it feel better? And now can I progressively overload it so that I build up tissue capacity so it's no longer an issue in the future?
And we'll drop some links below to some of those training aids that, depending on what diagnosis is, might be beneficial to you.
Yeah. We'll put the ones that we like most at our clinic, and we're going to run through all of those today. It's going to be the next thing we hit.
So what can you do to make your knee pain feel better?
There's 4 non-negotiables that I'm always looking for. First one is you have to have complete knee extension. You have to have complete knee flexion passively. You have to be able to get your quad incredibly strong. So despite the fact that everybody obsesses on the hip right now, and I don't disagree that your glute should also be strong, your quad is your primary force absorber. When you walk, when you do any activity where it involves load, your quad is the most important muscle. And then undergirding that is every other muscle that helps to absorb force. So that's your glute max, your glute med, your TFL, your hamstring, your pretibial muscles, your posterior tibialis, all the plantar flexor muscles, even the plantar intrinsics, the muscles that stabilize the foot. That's your whole force absorption chain. Those have to be incredibly strong. And then the final one is you don't have any swelling inside the knee joint. There's a really interesting amount of literature where it talks about a term called arthrogenic inhibition, which I like to use and not explain to people. So
is that AI?
Smarter. Yeah. Oh my, that's actually funny. I would have put that together. So no, it's not AI. It is where you irritate the joint swells it doesn't always have to be swelling, but the joint actually turns your muscles off.
I feel like I've got fat knees. So like I've just been at a volleyball tournament in the past, like, oh my gosh, did you hurt your knee? And it's like, nope, I just have fat knees. Or maybe it's the muscle around there, but yeah, generally it's
could it be the
fat knees.
Joint effusion or joint swelling? The knee capsule is humongous. Have you heard of the term capsule?
Yes.
Right. So that every structure, every synovial joint, every movable joint in your body has a capsule that surrounds it that keeps the synovial fluid. It keeps it all inside the knee. Now, what can happen is that capsule itself can get really irritated, and that capsule is humongous. And so you can actually catch swelling in the knee in a way that you don't in any other joint in the body.
Oh.
What you can do is called the brush and sweep test, where you basically look and assess. And if you see, and it's one of the things that we train any of our people who come in with a joint irritation, we teach them how to catch subtle joint effusions, because if it happens, your quad and your glute are most likely going to shut down. And it has nothing to do with strength. So if you're one of those people who's been doing an endless amount of glute exercises, and then every time you go in, somebody tests it and they tell you you're weak, you have an inhibition issue, which is incredibly important, because the only way you can address it is by first getting your joint swelling under control, which can only happen if you're actually treating your joint well. And then number two, you have to activate all the time. It's not about strengthening. It's about repeated activation, especially during whatever activity that's bothering you.
You can have swelling that's not necessarily an injury per se then.
Joint effusion is really common in the knee. If you have a rapid onset of joint effusion, of joint swelling, you can have actually bleeding inside the joint, which is not good. But you can have synovium that gets really irritated, and you'll start to have this excessive fluid. So your knee joint doesn't have a blood supply. It's avascular. So it's not one of those things where there's a blood supply. It actually has to diffuse across your bone and your cartilage into the joint. And then that synovial fluid is actually very nutritious to those structures, those intra-articular structures. And what can happen though is the rate of diffusion can get too fast. It's almost like you're getting too much fluid coming in, and it can't come out fast enough, and you'll gather up this excessive swelling. You'll hear terms of it: water on the knee, my knee feels swollen, or I can see that it looks different than the other side. That could be quad muscle loss, but oftentimes when somebody says that, I'm thinking, oh, I bet they're having recurring instances of joint effusion. That can be a kind of a whole bunch of different problems, but does that immediately mean that you have to get like a total knee replacement, or you should shut down and not do anything with it? No, it means you have to manage it really well.
Tiger balm and ice.
As long as you're using baggy on your hand, you can use Tiger Balm. I freaking love Tiger Balm. That's actually a situation where Tiger Balm would be a horrible decision, because every time that you do that, you're losing the feedback loop.
I do see, big volleyball tournaments that after every match, folks are just putting ice on both knees. Good or bad?
I would not. I would compress it. Ice on it, you're going to block some of the signals. Instead, what I would be doing would be repetitive motion on it, make it feel good, and then I'd be doing constant quad activation and glute activation, because those things will actually make it feel better, and then I'd have some aspect of knee traction.
Alrighty.
That's
interesting.
Right, over and over and over and over.
I feel like, after a match, you've just done repetitive knee motion for however many reps, and it's like you just need to do more to get that swelling.
It's a good point. The way you just said that, so it's not loaded. I would say if you have access to a bike and you're spinning on it, and it's not going into end range positions, your knee will feel dramatically better than if you just ice it. I find in that situation that ice does not work well. All it works well with is blocking this pain signal. It blocks called your nociceptors. I think it blocks some of those things that are telling you it hurts. And then when I've tried to get people after they've done the ice, get them back and ready to play again, I find it way more difficult than, okay, keep it loose. You're basically, by doing the cyclical action on the bike, you're helping to promote that diffusion that we were just talking about. And I find that it reduces how often people have a massive inhibition response and a massive painful motion loss.
Wow. Okay. That's a different perspective than I'm used to hearing.
Yeah. I don't think it's managed well, especially when somebody has, just to use that as an example, use like a volleyball tournament. When I've had to keep somebody going through a full day of activity, I will traction it, quad activation, soft tissue massage, and I'll hit that over and over again with the idea every time that they step up and they move and they walk around, I want it to feel loose. What I find as a report back from people when they do ice is they feel tight. I'm not like that doesn't even make sense. So you're doing something that we know will inhibit your muscle activation. It'll block your feedback loop that tells you you're doing something that overloads it. I just think even from like a whole thought process, it's multiple stupid things in a row. So the whole idea is that you're trying to manage swelling, which I guess is kind of the thought process.
Right.
I don't think it does that. I don't think it reduces the swelling at all. I think it just obliterates your feedback loop. And then when you try to get warm again, it's more difficult. So I don't find it that useful.
Just dropping knowledge over here. I feel like unpopular opinion maybe, but
so anybody that doesn't somebody doesn't think that, take me up and I'll do it for you. Like, come by, I'll show you how to do it. That's not I would be surprised if you find that doesn't work for you. And if it doesn't, what I would say is that you've gotten used to blocking and compensating for symptoms. You're actually not correcting your problem, which is your force absorption chain must be totally crap because you're overloading it constantly.
Now you're just being mean.
I'm down for this. Even if I don't know what a spike is, topping the ball.
Artificial stabilization. Taping knee braces. I see a lot of knee braces at the volleyball tournaments I go to. I even used one, and it's got like some padding in it that you could, kind of use as your knee pads. I've never really worn knee pads, but I bang my knees, bang them on the floor all the time. So.
Bang it out.
Yeah.
Why don't you wear knee pads?
I just feel like they're uncomfortable and don't give me the range of motion I want for all the other activity I'm doing.
When you hit the ground, does it hurt?
Yeah.
Yeah. Okay.
Yeah.
Yeah.
So like I started wearing one a couple of years ago, just on one knee, and that's the knee I primarily go when, I'm getting low for a dig.
I'll learn the terms. So when you're digging it out.
No. Volleyball.
So you're going for, I love that. We should have that. Volleyball vernacular. You're doing a dig. Okay. So you're doing a dig. You know what I find funny about that? The amount of times where people have been trained in volleyball to hit their knee really hard with no force absorption whatsoever. That's one of the more common issues that I do see in volleyball is people will train themselves to give themselves traumatic synovitises, like literally a jammed knee joint. They will genuflect hard, half kneel right into the ground to
I don't do that.
Okay. That's why you don't need knee pads.
Right. There are times where it's unavoidable and you've got to dive and you're going to probably bang your knee, but I generally just try to do that on the one side that I have a knee brace with padding on.
Makes sense.
Yeah.
Yeah.
Like taping, I see a lot of folks doing jumpers knee tape where you're taping below the kneecap.
What are they doing? Are they doing it with a stiff tape or like a...
Sometimes it's just with like a pre-wrap type thing where it's rolled up. I'm sure you've seen this in the basketball community.
I have. I personally, so if I have to put a thought process around it, it just depends on what the pain generator is. Oftentimes people, I think me and you talked about this, one of the diagnoses, if we start to kind of run through the whole list of them, a lot of diagnoses are what we call extensor mechanism injuries, where it's the quadriceps linking to the quad tendon, to the patella, to the patellar tendon, to the tibial tuberosity. And that's that whole thing where you're generating force through your extensor mechanism. It crosses the front of the knee joint. And so you'll see tools that try to reduce overload that's happening to one of those components. So say you have a quad strain. Well, a thigh wrap works beautifully for that because you're compressing the muscle belly, which actually helps every time you squeeze a muscle, like where you activate a muscle, there's a broadening effect against the fascia that overlies the muscle, and that stiffens the whole force absorption chain. And sometimes where that gets irritated, you can use a thigh wrap, which works beautifully. Sometimes it's the quad tendon. So then we're putting a strap over the quad tendon where you compress the tendon. I find that can be really helpful with load transmission. You can do the same thing for the patellar tendon. And then the other piece that's always interesting is you can have a patellofemoral joint irritation, or we call arthropathy, but that's a joint itself as well, that patella where it rides on the femur. And you can do different glide techniques with taping a medial or a lateral glide, and we can just test it and see if it takes away the symptoms. So you can do any of those things to augment it, and I freaking love doing that.
That's like a
I love
PFP pain.
it. Could be a PFP pain, and what I find is people will say they have patellofemoral pain syndrome, which is what a PFP would stand for. Sometimes when people throw syndrome on it, it means that they weren't very good at doing the local exam or the structural exam. They didn't actually identify what the true pain generator was. So there again, you can't be as specific with your artificial stabilization. I think that's a mistake. So for example, okay, I'm catching that you have a myofascial issue in your quad. Okay, I'll use a thigh strap. Oh no, it's your patellar tendon. Okay, I'll use something to compress the patellar tendon, but I'll test it and make sure that it actually feels good. But then you can also have stuff where what's happening is your knee is diving in, and you can use a surf strap and you force the femur to stay externally rotated, and you now have solved the problems. I freaking love artificial braces, artificial tools like this. I really like it when it's specific. I just about died right there. I like it when it's specific. Oh my God. You see, I'm about to stroke out how irritated I am. I think that sometimes happens. I'm not a huge fan of kinesio tape. I don't think it's stiff enough to control mechanics. Sometimes I think things are used that aren't as effective. You can, if it's helping you, I don't want to say don't do it, but I think there's ways that you can adjust it. And we're not going to have it today, but we'll walk through all of the things I just said as tools that you can use. Otherwise, this can be like a 9-hour episode.
I still remember when KT tape, kinesio tape first came out, and there were, adult volleyball players just slathering their whole body in it. It's like from, the toes all the way up to their neck. There's just, 40 pieces of KT tape on. And
that's funny.
Yeah, I wonder if it even helped. Let's jump into some exercises that you would suggest for knee pain or to help reduce knee pain.
I'm going to show you a whole bunch of stuff that does not guarantee to take your knee pain away, but I want to make sure that you understand that there's a whole bunch of stuff that you could try, and there's a whole bunch of different reasons why you would actually try it that would be helpful depending on actually what problem you have. Could I explain that any more poorly?
That was great.
There's a lot of words to say. None of this will guarantee to make your knee pain go away, but it could be helpful. And what's really helpful is understanding what your problem is. So real quick, we're gonna run through a few of these things. You ready?
Ready.
Yeah. Okay. First one is if we think that there's a quad component that we'll do that's part of the pain, we can strengthen the quad. The easiest one is a straight leg raise or a quad set. Straight leg raise is just you squeeze your quad and now lift it up and then go back down. And you're going to keep it squeezed the whole time. Now, the big mistake on this one, when people have a quad weakness, is that when they transition, their knee will bend, let it bend just a bit. And we'll see this, like they can't keep it up. We call that an extensor lag. We don't want to see an extensor lag. We want to see that this stays tight and contracted the whole time. Now, the cool thing about the straight leg raise is if you have full knee extension, when you're doing this, it's actually a fantastic quad activator. Even if you're not doing it for pain relief, if you found that your quad has become weak, this is a great one if there's inhibition happening, as long as it does not hurt. Okay. Now another one, can you roll toward me? This is going to be more for your glute medius. You want to straighten your leg out. We'll do 2 of them. Now, because Alex has a TFL injury on the other side, we're not going to do it on the other side. This one I find to not be the one to go to if you have a TFL injury, but I'm still going to show it because it is a great hip abductor exercise. You're going to straighten your top leg out. You're going to roll forward more. You're going to lift up and then down. Same thing. It's a great exercise. We're targeting his glute medius. This is one where he feels it matters. So we want him to feel it kind of the back pocket. Right. Stop if you feel it in the front. You feel it? He doesn't feel it in the front, feels it only back. So that's actually a good exercise. All right. So go back on your back. Okay. So that's the most important thing just for activation of quad, activation of glute. Okay. So now another one that we like to use that can be good for quad activation and for mobilizing your meniscus is a terminal knee extension. And so what you're seeing with Alex right now is it pulling his tibia forward as his knee goes into extension. The meniscus is interesting because when your meniscus actually has to move out of the way of your femur or else it gets smashed. And so what this does is it pulls this tibia forward, which helps the meniscus glide forward relative to the femur as the femur is going over the top and rolling into full extension. Now, it should feel good. So this is a great one, like if you're noticing that you have a pinch in the front of your knee. Now, we're going to roll into a traction position that's really simple. Does it feel good? No. It's got a big ass calf. I love it. Alex's position here, he's actually doing a knee traction position. We call this an anterior knee traction with the band because we are not creative with our naming conventions. But what that's doing is it's providing a little bit of a pull. Now, if that's uncomfortable to Alex because of his massive calf, we can also pull over and go just right there. And what that does is it's gonna pull it forward. This will typically help to regain knee flexion, especially painful knee flexion that you have due to you jamming your knee.
And we're back. We just showed a couple of exercises you can do. Care to expand?
It's more of the same. You need to know what the actual issue is and what's the structure that's causing your pain, what's the function that's driving it, what actually makes it feel better, and then what triggers are hidden and obvious that are making you feel worse and lose tissue capacity. Those are the biggest things. Really what I want to get across is there's so many options. There's almost like an endless amount of treatments that you could do, but what really matters is you understand what the problem is, and then you develop a way for you to make yourself feel better. And then underneath all of that, after you have those two skills or those two things done, progress your tissue capacity so it quits coming back.
Why does knee pain keep coming back, and how do you manage flare-ups?
I honestly think that knee pain keeps coming back because people don't actually build tissue capacity. So they don't actually finish out a full rehab plan. They get in this mindset, which, okay, I mean, it sells on YouTube, but it's not as simple as a single exercise. And if it's something that keeps on returning, you either have an unmanaged trigger, a tissue capacity that's not good, and you probably haven't actually addressed the root issue. There's nuance and complexity to it. You can try to pull it apart, which is fine. And I love when people continue to be active and they try to figure out their own problem. I'm totally cool with it. But the idea that joint, which is the most commonly injured joint in the lower extremity, when you look at like running, other competitive activities, it's just a joint that's predisposed to being injured. This deals with massive amounts of forces every time you take a single step, which we didn't even get into the gait analysis today, which we'll have to do in a future episode. It's more complicated than you didn't do a stupid exercise correctly. If you change your mindset around it, you can actually build capacity, tissue capacity, and quit blowing it up over and over again. And if you don't, I think you're going to be stuck in a recurrent injury hell.
Yeah, I'm just realizing like we didn't talk about isometrics. I think there's a ton of isometric exercises that can help for more competitive athletes that have knee pain. Yeah, I think there's so much more to this that we could probably go on forever.
Treatments, there's so many different treatments. I'm not against any one of them. When we do case reviews, our team does 2 hours of case reviews on a weekly basis. It's part of what I think is one of our advantages as a business at Smith Performance Center. And the complexity of the thought process and the underlying way that you work through a problem, it can make it seem like that the solution at the end is actually simple. A lot of thinking that goes through and it's tested, and theories that are put forth need to be able to be tested and verified that you actually have the right answer. And you have almost an endless number of treatments. So if somebody defines themselves by the treatment they provide, that's a weak clinical thought process. It's weak. And I don't mean that to be overly negative. I guess I do mean to be negative. But if you define yourself by a treatment and not by the way you think through a hard clinical problem, you're going to get lucky with some people because some people will respond to treatment, but it's not, you don't have a way to work through when that simple treatment doesn't help them.
All right. I think that's a good place to close it out.
Yeah, cool.
Drop a comment below if you like my shirt. Also, if you have knee pain, if you've got some knee pain, drop a comment below, and Craig's happy to look at your case.
I would love to do a full case study. So if somebody wants to have us do a complete deep dive on their knee,
let us know.
I'm totally game. He was throwing a ton of shade at my shirt before we started. I didn't realize.
Nice. It looks nice. It just doesn't feel nice. It's got an odd texture to it. But
Is it weird to anybody else that he felt my shirt? I thought it was weird too. So,
all right. Drop a comment below. Like, comment, subscribe. Aside from that, have a good day.
P what P, baby. See you guys.